Hello and welcome. We're about to take a deep dive into the clinical world of hypoparathyroidism.
Educational content by Dr. Mohammed El-Nagi Mohammed. In this explainer, we're going to give you a really high-yield clinical overview of hypoparathyroidism and PTH resistance. This is perfect for you busy clinicians out there, and especially if you're gearing up for specialty exams like the MRCGP AKT.
So here's how we're going to tackle this. We're going to build it up like a differential diagnosis. We'll kick things off with the most common cause. Then we'll look at the clinical signs, and from there explore the conditions that can mimic it, and crucially, how to tell them all apart.
Okay, first up, primary hypoparathyroidism. This is really the foundation for everything else we're going to talk about today. So what's at the heart of this? It's actually pretty straightforward. The parathyroid glands just aren't making or putting out enough parathyroid hormone, or PTH. And it's this fundamental lack of PTH that's driving all the biochemical changes we're about to see.
Now, in the real world, the most common reason you'll see this is iatrogenic, meaning it's caused by medical treatment, usually damage to the glands during neck surgery, like a thyroidectomy. And here's a little pearl for your exams. Even though it's technically secondary to a procedure, we still classify it as primary hypoparathyroidism. Why? Because the problem is now intrinsic to the glands themselves. It's a subtle but really important distinction to grasp.
This lack of PTH gives us a classic biochemical triad. First, without PTH, you get less calcium pulled from the bone and less reabsorbed in the kidneys, which leads to low calcium in the blood, hypocalcemia. Second, the kidneys can't get rid of phosphate properly, so phosphate levels go up, hyperphosphatemia. And of course, the PTH level itself is low. This pattern, low calcium, high phosphate, low PTH, is a hallmark you absolutely need to recognize.
So how do we manage it? Well, it follows logically. We just replace what's missing to get things back in balance. Treatment is all about supplementing with calcium and an active vitamin D analog. Alpha-calcidrol is a really common choice here. And this is key because PTH is needed for that final step of activating vitamin D in the kidney. Alpha-calcidrol completely bypasses that step, allowing the gut to absorb more calcium.
Now, it doesn't matter what the underlying cause is. When calcium levels get too low, you see a very distinct set of clinical signs, and it all comes down to increased neuromuscular excitability. The classic acute sign is tetany, that involuntary muscle twitching, cramps, and spasms. But often, a very early sign is perioral paresthesia, which is just a tingling feeling around the lips. Now, if it's been going on for a while, you also have to look for things like depression and even the development of cataracts.
Trousseau's sign is one of those classic bedside tests to unmask what we call latent tetany. So what you do is you inflate a blood pressure cuff on the arm above their systolic pressure, and you leave it for about 3 minutes. The ischemia this causes makes the nerves more irritable. In someone with low calcium, this will trigger a really characteristic carpal spasm, flexion at the wrist and in the knuckles.
And in a similar vein, we have Chopstick's sign. For this one, you just gently tap on the facial nerve, right in front of the ear over the parotid gland. A positive sign is when you see a twitching of the facial muscles on that same side, especially at the corner of the mouth.
Okay, huge point here, especially for your AKT exam. Low calcium directly affects the heart's electrical cycle, specifically repolarization. And on an ECG, this shows up as a prolonged QT interval. This is a classic must-know association and a potential emergency, so definitely commit this one to memory.
All right, so now that we have that foundation, let's make things a little more complicated. We're moving into the territory of a great mimic, pseudo-hypoparathyroidism.
So what in the world is going on here? Well, the parathyroid glands are actually working perfectly fine. In fact, they're working overtime, pumping out tons of PTH. The problem isn't production, it's reception. The target tissues, the bone and the kidneys, are resistant to PTH's effects. It's usually due to a genetic defect in the G protein signaling pathway. So the hormone is there, but the message just isn't getting through.
This condition, also known as Albright's hereditary osteodystrophy, often comes with a very distinctive set of physical features. You'll want to look for short stature, maybe some developmental delay, and a really characteristic shortening of the 4th and 5th metacarpals. This is what creates that classic knuckle-knuckle-dimple-dimple sign when the person makes a fist. Now, the lab results are what really sets this apart. Because of that end organ resistance, you still get the low calcium and the high phosphate. But, and this is the key difference, the PTH level is high. The body senses the low calcium and tries to compensate by churning out massive amounts of PTH. This is the biochemical signature of PTH resistance.
So that critical difference in the PTH level,
Low in deficiency versus high in resistance is our main clue, and it guides our next step, which is a functional test to really nail the diagnosis.
So here's the clinical puzzle, right? You have a patient with low calcium and high phosphate. Sure, the PTH level is a huge hint, but how can we functionally prove what's going on with the PTH axis? The answer is the PTH infusion test. It's a pretty elegant idea. You give the patient an infusion of lab-made PTH. Then you measure the downstream effects in their urine. Specifically, you're looking at two things: the levels of cyclic AMP, which is the second messenger for PTH in the kidney, and the levels of phosphate, because a normal response to PTH is to pee out more phosphate.
Now, interpreting these results is everything. In primary hypoparathyroidism, the kidneys are perfectly healthy and ready to respond. So when you give PTH, you see a nice healthy rise in both urinary CAMP and phosphate. Simple. But in classic type 1 pseudo-hypoparathyroidism, the resistance is upstream, so you get nothing. Neither CAMP nor phosphate levels go up. And then there's the rarer type 2, which is super interesting. You do get a CAMP response, but you still don't get a phosphate response, and that tells you the defect is somewhere downstream of that second messenger.
All right, we're on the home stretch. Let's look at one final, related condition that shares a very similar name and appearance. This brings us to the wonderfully named pseudo-hypoparathyroidism. What's so fascinating here is that these patients have the exact same physical features, the short stature, the shortened metacarpals, but their biochemistry is completely totally normal. Their PTH system is working just fine. This is all down to something called genomic imprinting. Basically, they inherit the faulty gene from their father, which, for complex reasons, only causes the physical features without the hormone resistance.
Okay, let's finish with a quick challenge to pull it all together. You have a patient who presents with tetany. Their labs come back showing low calcium, high phosphate, and a high PTH level. So with that classic picture of end organ resistance, what's the most likely diagnosis? It's gotta be pseudo-hypoparathyroidism. Thanks for joining me for this deep dive into the nuances of PTH disorders.